Okay, छोटे लोग. So let's talk about the thyroid gland. Now, thyroid gland, two lobes, one isthmus, production of T3 and T4 hormone, plus calcitonin. T3 and T4 is coming from the blood vessels, the follicular cells, and the colloid. And the parafollicular cells, it produces calcitonin, which is important for your calcium homeostasis. Now, one time a question has come on the thyroid biopsy where they had asked what are the cells. They have marked the parafollicular cells. तो देखो हमेशा याद रखना that these are your follicles, okay? And in the follicle, this pink color thing is your colloid. These cells, the round cells which you are seeing, these are your follicular cells. And in between the two thyroid follicles, the elongated cells which you are seeing, these cells, these are your parafollicular cells. Okay, and these are the cells which are required for production of calcitonin. Okay, now once we are making a thyroid hormone, I told you before that you require iodine, you require thyroglobin, which is giving you a tyrosine amino acid. Okay, so from where you are getting the iodine? From your blood in the form of iodide. It comes inside from the blood. ये blood से आया बेटा. And after that, this iodide will convert into iodine when it goes into the colloid. Secondly, your thyroid follicular cell is going to produce what? It is going to produce thyroglobin, which is going to give you tyrosine, and this thyroglobin molecule also comes inside the colloid. Now, this thyroglobin and iodine, they both will combine together and they will make MIT and DIT. This MIT DIT, monoiodotyrosine and diiodotyrosine, they will do coupling reaction and they will make T3 and T4. Now, this will be stored in the colloid. Now, whenever your body, different parts of your body requires T3 and T4, the thyroid hormones, the signal will come to the thyroid gland, the signal will reach to the colloid, and this colloid will leave this T3 and T4 into the thyroid follicular cell. And then from the thyroid follicular cell, it will come into your blood. Some T3 and T4, they come alone, not bound with the protein. You call them as free forms. And some comes with the protein and you call them as bound forms. So there are three steps which I want you to learn. These are your oxidation, when your iodide is converting into iodine. Second is organification, when your thyroglobin and iodine, they are making MIT and DIT. And third is coupling reaction, when MIT and DIT are making T3 and T4. Okay, all three, they are happening in the colloid, and all three requires an enzyme called as peroxidase. Why I want you to remember this, that whenever a patient is having hyperthyroidism, that means that more T3 and T4 is being produced, we can just block the peroxidase enzyme working. And once we block the peroxidase enzyme working, all these steps will not be taken place and you will not be making T3 and T4. The drug which can block the peroxidase enzyme is PTU, propyl thiouracil. Okay, then your, which is the hormone which you are making more, is T4, and the hormone which you actually require for functioning, that thyroid hormone, that is your T3. Why you are making T4 more? Because the half-life of T4 is more. It is around 7 days. So once it is coming into your blood, it remains around for 7 days, and that is why T4 is being formed more. What is hypo and hyper? देखो, whenever we are saying hyperthyroidism, so we are only talking about thyroid. To control the thyroid gland, your hypothalamus is secreting TRH, your pituitary is secreting TSH, and then your thyroid gland is secreting T3 and T4. So if they are saying hypothyroidism, matlab they are saying that the thyroid gland is functioning less. So T3, T4 will be less. Now, this hypothyroidism can be of three types: primary, secondary, or tertiary. When do I say that it's primary hypothyroidism? When T3, T4 is less, the problem is here, first floor. But pituitary and hypothalamus, they are normal, so they will ask the thyroid gland to produce more. So if one arrow will down, जो भी word thyroid के साथ लिखा है, the arrow will be according to that word for the thyroid gland. So it is written hypothyroidism. So matlab T3, T4 will be less. But if the other two, TSH and TRH, they are high, problem is only with the thyroid gland, primary. If two arrows are down, T3, T4 and TSH, but TRH is high, that means secondary hypothyroidism. And if all the three arrows are down, it is tertiary hypothyroidism. Whereas opposite, if T3, T4 is more, it is hyperthyroidism. But other two are less, matlab primary hyper. Two arrows up, secondary hyper. Three arrows up, tertiary hyper. When do we say subclinical? Subclinical word we are using only when the symptoms are not very prevalent. They're not very obvious symptoms that the patient is showing. So T3, T4 will be normal. Any problem regarding the thyroid symptoms that the patient is having, it is not because of TSH and TRH. Because the hormone which is coming from the thyroid is T3 and T4, and it goes and works on the various organs of the body. So symptom will come because of problem with the T3 and T4. The word I'm using is subclinical. That means the T3, T4 is normal. Organs are not showing the symptoms. But then why it is hypo? Because actually your body requires more. So your pituitary is telling your thyroid gland that please secrete more, but thyroid is working normal. So it is working less than normal. Because pituitary is giving the signal ज़्यादा बनाओ, but ये नहीं बना रहा है. So it is called as subclinical hypo, that T3, T4 is normal, but pituitary is asking more. And likewise, subclinical hyper, pituitary is telling the thyroid gland do not secrete the hormone, but it is continuously secreting. It is working normally. It should work less, but it is working normally. So it is hyper. But because it is working normally, so it is not giving hyper wala symptoms just now. Eventually it will. So it is called as subclinical hyper. Okay. Now, whenever we are talking about the functional hormone, that is T3, and it has got five functions like the growth hormones. Growth hormone also had five functions. These five functions are different, but both have five functions. T3, alpha receptor, beta receptor, metabolism, bone, and testosterone. It increases everything except the testosterone. So, alpha receptor more, it will increase the vasoconstriction. Beta receptor more, increase the heart rate. Metabolism more, weight loss. Osteoclastic activity more on bone, osteoporosis. And testosterone, it will decrease. That will lead to gynecomastia. Okay. Now, for hypo and hyper, मैंने आपको क्लास में भी याद कराया that just learn छोटू. Hyper मतलब सब ज्यादा. Everything will be more. And hypo मतलब सब कम. Most common cause of hypo, autoimmune. Most common cause of hyper, autoimmune. So autoimmune destruction of the thyroid gland will lead to hypothyroidism. Autoimmune activation of the thyroid gland will lead to hyperthyroidism. Destruction of the thyroid gland will happen in both eventually. But one is due to activation and one is due to destruction directly. The disease which is for hypo more commonly, it is your Hashimoto thyroiditis, and disease for hyper is your Graves' disease. Other cause of hypothyroidism could be iodine deficiency, and other cause of hyperthyroidism could be taking T4 from outside, or maybe some cancer related to the thyroid gland where the cells are increasing like that. Treatment, but for hypo, because the thyroid gland is gone, so you have to give the thyroxine from outside. And for hyperthyroidism, when T3 is becoming more, that is hyperthyroidism, right? So give alpha blocker, beta blocker. You have to give propylthiouracil to block the peroxidase enzyme, or you can give carbamazole, methimazole. Okay, so these are the hyper and hypo. Thyroiditis, Hashimoto thyroiditis, I just said that it is most common cause of hypothyroidism. It is autoimmune. And where are the antibodies? The antibodies, they are formed against two things. Either a thyroglobin, which is containing tyrosine, very important for your T3, T4 production, and peroxidase. Peroxidase enzyme is very important because if the peroxidase enzyme is not there, you'll not be able to do OOC, oxidation, organification, and coupling reaction. So both these antibodies, they are going to disrupt the thyroid gland. Eventually, you are storing the T3, T4 in the thyroid gland in the colloid. So once you are destructing the thyroid gland, this stored T3 and T4 comes in the blood, and the patient initially, transiently, the patient will go into hyperthyroidism. And eventually, because the thyroid gland is destroyed, the patient goes into hypothyroidism. So you have to treat for both. You see Hurthal cell in the patients of Hashimoto thyroiditis, and Hashimoto thyroiditis can be learned by the mnemonic Hashimoto. It is hypothyroidism, it's autoimmune. You need synthyroid treatment. That means you have to give for both hypo and hyper. Hurthal cell is seen. Initially it is hyperthyroidism because the stored T3 and T4 is coming out. It is associated with marginal zone lymphoma. It will give you goiter. Okay? Cystic goiter will be there. And the antibodies, the most important thing that it is TPO and TG antibodies and lymphocytic infiltration because matlab, it's not an acute disease, it's chronic, right? So it will take a little bit of time. So lymphocytic infiltration can be seen. Subacute thyroiditis or decruence, word kya yaad rakhna beta, it's viral. And the main problem of the patient would be virus destroying the thyroid gland, so pain. So main treatment is NSAIDs. The moment virus gets out of the body, the thyroid gland comes back to normal. So sometimes we don't have to give treatment to the patient for any thyroid problem. The major treatment will always be NSAID. Riddle's thyroiditis, it's idiopathic, we don't know, but there's a massive destruction which is happening in the thyroid gland. And patient eventually goes into hypothyroidism. And we know hypothyroidism का treatment तो L-thyroxine है. But because there is a massive destruction which is happening in the thyroid gland, so it leads to a lot of fibrosis, and you can give tamoxifen. Then Graves' disease and toxic adenoma, they both are hyperthyroidism. Graves' disease में क्या होता है बेटा? TSH receptor which is present on the thyroid gland, which actually is taking, TSH signal from the pituitary. This TSH receptor ke against you make antibodies. So what are the antibodies for Graves' disease? Anti-TSH receptor antibody. And what they do not destruct. They overactivate the TSH receptor over the thyroid gland. And overactivation of TSH receptor over the thyroid gland will lead to more production of thyroglobin. Indirectly, it also activates your iodine receptor and you will take more iodine inside. So now you are having more thyroglobin, more iodine. So obviously there will be production of more T3 and T4 and the patient will go into hyperthyroidism. So hyperthyroidism because of overactivation of the thyroid gland due to gain of function mutation of TSH receptor, because of presence of TSH antibody, TSH receptor antibody, it is called as Graves' disease. It's type 5 hypersensitivity. If not type 5 given in the options, go with type 2. All right. Toxic adenoma, no hypersensitivity. We don't know why. Autonomous overactivation of certain parts of the thyroid gland, and therefore, what kind of goiter you will get? Multinodular goiter. Whereas in Graves' disease, because the entire thyroid gland is working more, so you will have diffuse swelling. So, diffuse goiter, Graves' disease, multiple small things, it is your toxic adenoma. In both of them, the radioactive iodine uptake scan will show you more iodine being utilized by the thyroid gland. So if they ask you what happens in RAIU in both of these diseases, बढ़ ही जाएगा, but the pattern will be different. In Graves' disease, because the entire thyroid gland is working more, so it will be all black. Whereas in toxic adenoma, because there are some portions of the thyroid gland which are working more, so it will give you patchy involvement like this. Now, whatever features you are getting in the Graves' disease, that is due to a presence of a glucosamminoglycan, and you do not have this deposit in in toxic adenoma, the GAG deposit. And what are the symptoms of the Graves' disease? It is, diffuse swelling. You have thyroid acropexy. You have pretibial myxedema, and you will have exophthalmos. For treatment of Graves' disease, because it is hyperthyroidism, so all the medications blocking, they can be used. And if at all you need to remove the thyroid gland, please remove it by doing the surgery. With this toxic adenoma, obviously final treatment is surgery because it's adenoma, you need to remove it. So it will be surgery. Then thyroid storm. In thyroid storm, it is excessive stimulation of the thyroid gland due to XYZ reason, and patient is having severe hyperthyroid features. So you have to give, iodine blockers so that there is no iodine being utilized because we are eating iodine, right, in the salt. So we give iodine binders so that this iodine in the blood binds and do not go inside the thyroid gland. We also give antithyroid medications and we have to give IV fluids because the patient will be hyperthyroid, losing a lot of water. So we need to take care of that. Myxedema coma, it's severe hypothyroidism due to, patient not taking the thyroid medications, or there is some problem, the hemodynamic problem because of which the thyroid gland is destructed. So patient goes into severe hypo. And it is so severe in hypo, I said everything goes low, right? So the patient goes so severely, hypothyroidism that all the metabolic functions, all the normal hemodynamic functions will go down. So severe bradycardia, severe constipation, hypotension, everything will be very low in these patients, and you might see these patients in ICU settings. So what you have to give, now, oral, but for any hypothyroidism, what is the treatment? Give the thyroid hormone from outside. You cannot give them oral. So you have to give them IV thyroxine. Okay. And CQ thyroid syndrome, in this, see, your thyroid gland secretes T3 and T4, and then they are in the blood. Majorly, you are secreting T4. And then in the blood, your T4 is converting into T3. This is called as peripheral conversion of T4 to T3. Whenever a patient is sick, severely sick, it is seen that this peripheral conversion of T4 to T3 is blocked. Because severely ill patients, they are blocking the enzyme which is converting your T4 to T3. And what is that enzyme? Deiodinase. You remove one iodine from T4 and make it T3. So that deiodinase enzyme, which is peripherally converting the thyroid hormone, that is gone. So you're not having T3. Now, once you do not have a T3, your pituitary should give the signal to the thyroid gland, secrete more. But Pituitary is giving the signal to thyroid gland by secreting what? TSH. But once you check TSH of these patients, you find that the patient's TSH is normal. You see the T3 and T4 overall value of the patient, you find the T3, T4 is normal. But patient is giving you symptoms of hypothyroidism, severe hypothyroidism. Why so? Because in severely ill patients, the peripheral conversion is gone, but the central conversion, where you are converting your T4 into reverse T3, that's there. And reverse T3 is an active form of T3. So your pituitary feels that you have T3 in the blood, but that T3 is reverse T3 and that is non-functional. So your pituitary doesn't overstimulate. Pituitary thinks everything is fine. So patient having severe hypothyroid features, but the investigations are euthyroid. And this is called as CQ thyroid. Okay, so in CQ thyroid, the peripheral conversion is blocked, the central conversion is still happening, and that is why all the thyroid function tests they remain normal. The only thing which will be lost is free form of T3. The active form of T3 will not be seen. Okay, so these are the entire discussion of thyroid, formation of hormones, hyper, function of T3, and all the 8 forms of thyroiditis we have done. With the parathyroid gland, but I hope you remember. So PTH wants what? Calcium ki pappe. Okay. So PTH works on the bone to absorb more calcium. And every patient of hyperparathyroidism, जिसमें PTH ज़्यादा है, it will work on the bone, it will start the osteoclastic activity, and it will cause bone resorption, which will increase the calcium in the blood. Now, calcium and phosphate, they are हीर रांझा, Romeo Juliet. प्यार बहुत करते हैं पर साथ रह नहीं सकते. So phosphate, which is there in the blood, it is being excreted by the kidney. And whenever PTH is more, two direct things will happen. Calcium will be more, but phosphate will be less. Because calcium and phosphate, they're inversely proportional to each other. Okay, why body wants to manage them? Because they can cause atherosclerosis. They bind together, calcium phosphate, and they can cause atherosclerosis. We don't want that. So this is the mechanism God has given us, that whenever calcium rises, phosphate is being excreted by the kidney. Okay. Now, because you're eating a lot of bone, so indirectly, not directly, but indirectly, the osteoblastic activity increases, which actually increases the bone formation, actually increases the bone turnover time, and it increases the sap in the blood. Sap is what? सांप नहीं है ये, sap है. Serum alkaline phosphatase. It might be written as ALP, alkaline phosphatase. एक ही बात है. ठीक है? So this sap will increase indirectly. So whenever PTH will be more, your SAP will be more, because your PTH more will increase more calcium in the blood. It will cause more bone resorption. So you will make more bone indirectly. But if the PTH is low, that means you are not eating too much of bone. So your SAP will not be low. You're not eating bone, SAP is normal. But if you're eating bone, then SAP will increase. And when do you eat bone? Your body eats bone when your PTH is high. So if PTH is high, your calcium will be high, your phosphate will be low, and your SAP will also be high. But if your PTH is low, your calcium might be low, your phosphate is high, but SAP will be normal, because SAP is not directly related to PTH. Okay? There are 4 diseases we have to discuss: the primary hyperparathyroidism, primary hyperparathyroidism, secondary hyperparathyroidism, hypoparathyroidism, and pseudo hypo. तो बेटा प्राइमरी में तो क्या होगा? पीटीएच हाई, calcium high, phosphate low, and sap high. It will cause hypercalcemia in the patient because there is too much of calcium, and this calcium can deposit various parts of the body because the calcium is more inside the blood now. So it can deposit at different places. So it can cause renal stones, it can cause hypertension, it can cause brain problems, it can cause heart problems. So there can be multiple things which can be present in the patients of primary hyperparathyroidism. How do you treat it? You treat it by giving a drug called as ibandronate. You treat it by giving a drug called as evandronate, and because the cause is the tumor in the parathyroid gland, so it you might remove it. Now, secondary hyperparathyroidism is seen with CKD, chronic kidney disease. We had discussed this in the renal chapter. In chronic kidney disease, the calcium is low. Whenever the calcium is low, PTH will be high. So high PTH, because of low calcium means phosphate high. And because PTH is high, now it will eat up the bone. So you need to make the bone, and that therefore SAP is high. So all the features of CKD will be seen in these patients, and you have to treat the CKD. Hypoparathyroidism when you're destructing the parathyroid gland, autoimmune destruction, or maybe due to thyroid surgeries. When you do not have the parathyroid gland, PTH is low, PTH is low, calcium is low, phosphate is high, PTH is low, no bone eating. So bone formation is normal. You see Trossius sign and you see Chevostek sign, and you have to remember that hypocalcemia, which is happening in this patient, is a major problem in comparison to hypercalcemia. हाइपोकैल्सीमिया जब भी होता है ना पेशेंट को बेटा सडन डेथ हो सकती है पेशेंट की सो यू ऑलवेज हैव टू डू HSTCG because calcium is inversely proportional to QT interval. So any patient who is having hypocalcemia will have high QT interval and you have to manage that patient quickly. Otherwise, laryngospasm can occur and the patient might die. You also see these Trossel and Savosek sign. These are what? Muscles are getting irritated. Okay, so twitching, tingling will be seen in the patients. So obstetrician hand and your muscle twitching like that. Okay, and your pseudo hypoparathyroidism, बेटा इसमें क्या होता है pseudo hypo मतलब pseudo मतलब झूठ, hypo मतलब less. So है नहीं less पर लग रहा है less. It is not less but it feels like the PTH is less. Why? Because PTH का काम क्या है बेटा? PTH causes bone resorption. PTH also tells the kidney to remove phosphate. So there are receptors for this PTH on the bone and on the kidney. Those receptors, they malfunction. Why? Because there's a gene which is controlling these receptors. And what is that gene? GNAS gene. So if there's a defect in the GNAS gene, defect, your PTH will be secreted, but it will not be able to function. So you'll find PTH more, but it is not functioning. So what will happen to calcium? It will be less. Phosphate high and SAP normal. You see archibald sign, which is your knuckle, dimple, dimple. Right now, knuckle, dimple है ना, वो तो knuckle, dimple, dimple हो जाता है. What is the treatment? Remove the gland. Calcium mimetic drugs. You can give calcium mimetic drugs in these patients because in patients में हो क्या रहा है हाइपोकैल्सीमिया वाला टेंशन है ना बाकी इसका कोई ट्रीटमेंट नहीं है बिकॉज ये जेनेटिक डिजीज है लेकिन आप इसको सपोर्टिव मैनेजमेंट करते हैं ठीक सो दिस इज योर hypoparathyroidism, pseudo hypoparathyroidism, primary hyper and secondary hyper. So I hope that this quick recall of your thyroid and parathyroid will help you. I'll see you in the next video of adrenal gland. Take care, Chodo.